Hello, good evening, everybody. Just waiting for everybody to be pulled in from the waiting room. We've got quite a lot of sign-ups, which is great. I think we've had about 800 in total, 800 and a few. So I'm really excited about presenting this evening. So I'm just going to give it 30 seconds while we let a few stragglers come in and log in. Just a little bit of housekeeping before we crack on with the content of the old webinar. You'll notice you've got the slides, obviously, and my face, hopefully on your screen, and hopefully you're hearing me and seeing me. Do type in the chat bar, make sure you're hearing and seeing me all fine, and let me know where you are signing in from. You'll see next to the slides there is a chat function, and that has quite a few little cool features to it. So you can type in the public chat. That's for just general chit chat stuff. And then you'll see next to that is a Q&A tab. So what we'll do is we'll do a Q&A at the end. The Q&A section is quite cool. So you can type your question in there, and you can also upvote your favorite questions as well. Got some chat coming in. Excellent sound, Gaynor says. So really nice for that. But we've got someone from Stockport, someone from Netherlands, Peterborough, Brighton. That's great. People coming in from all over the UK and also the world. Wisconsin, brilliant. Kyle Gibson. Oh my goodness. Okay, now it's starting to go faster than I can read. So I'm going to ignore the chat now. But thank you for putting that in there. Yeah, like I say, don't forget to use the Q&A tab as we go. And it seems to be starting to settle off on numbers, so we'll crack on. There will be a recording of this, which I'll make available as well. I'm going to put it on my YouTube channel for probably about a week after this evening, and we'll see how that goes. Okay, so we're going to crack on. So obviously this evening we're going to talk about connective tissue disorders. I've named this a couple of different things. I'd named it connective tissue diseases when I first made the webinar, and then I can't change that because it changes all the links and stuff. So I've called it the presentation connective tissue disorders. Very quickly about me, I call myself a rheumatology specialist. That's what I do specialize in. I worked in rheumatology in the NHS in the UK for approximately 9 years, did everything you can think of in a rheumatology department. I saw new patients, ran clinics, diagnostics, investigations, you name it. I did it. I was very lucky, got to do a lot of CPD while I was there with some really awesome rheumatologists. That was really good fun. So I was very lucky. And over the last 6-7 years, I've been teaching and providing webinars all about rheumatology. Some of the rest of the time I spend working for Choose Health and Physio Matters and Therapy Live. We create CPD and various types of content, mostly for physiotherapists, but any musculoskeletal practitioner, osteopaths, chiropractors, so on and so forth. And occasionally I do try and go and play golf, which I've been doing today, and I did not put any sun cream on my face. So if I've got a little pink hue, then that's why we caught a little bit of the sun playing golf today. I do have a website, Rheumatology.physio, and that has loads of different resources on it, blogs and free stuff and videos and podcasts and you name it. Any type of content, I do create that. With loads of learning resources on there, and I do run courses, more longer form courses than this evening as well. And I do have some books which are available, which can supplement hopefully your clinical reasoning and learning. And I have written a new one all about connective tissue disorders. We'll come back to a little bit more on that at the end of the webinar as well. Just to let you know, you'll see little banners at the bottom. They will take you through to my shop as well. If you use the code Connective, then we're going to get a 20% discount on everything that's there as well. So if you want more of me after this webinar, then please do head over there. So let's crack on with connective tissue disorders. And we're going to do a very brief overview of these connective tissue diseases and disorders. Then we're going to talk about systemic lupus erythematosus, Sjogrens Syndrome, and then we're going to talk about undifferentiated connective tissue disorders. issue with some of these is they're difficult to say, and I apologize if I mix my words a little bit as we get through, and I've said them quite a few times. But what we need to really get into in this webinar that I'm going to talk about for the next approximately an hour, maybe a little bit less, is we're going to do an overview of these three conditions and their presentation, I suppose, and what you might see as they come into clinic. We're also going to give you a little bit of information around how they're managed medically, and also we'll talk a bit about investigations as well. So we're going to talk about bloods and very briefly touch on imaging at the end as well. So before we get cracking, I just want to talk a little bit about complexity. So if we look at this graph here, this sort of, I don't know what to call this really, but blob chart maybe, that I made a few years ago now. You can see up in the top left corner, we've got our connective tissue issues. I've popped in sort of green on their own. You've got Sjogrens Syndrome, you've got hypermobility syndromes, and you've got myositis. We're not going to talk about hypermobility syndromes or myositis today. Hypermobility syndromes aren't auto-inflammatory mostly, and that's where my specialty lies, really, is in the auto-inflammatory conditions. And myositis is significantly more rare than the other types. So just for the sort of mean of time as much as anything else, I've dropped those. We are going to talk about Sjogren's Syndrome, lupus, and mixed connective tissue disorders. Technically, rheumatoid arthritis is a connective tissue disorder, but obviously fits into its own category, really. So those ones over there are what we're going to talk about. But what I want to point out with this slide is this overlap that we see. So the synovitic or issues that can cause synovitis are widespread within the rheumatology sphere. Pretty much everything from ankylosing spondylitis to gout to rheumatoid to lupus is going to cause some level of synovitis. So it does make it very difficult. And we're going to intentionally ignore a lot of the other conditions, again, for the sake of time this evening, but also for the sake of not making this incredibly complex. And I do, as mentioned, run an entire day course, where we try and tease that out a little bit. So we are going to concentrate on those connective tissue disorders that I mentioned. So the first thing is a little bit of our overview here, and there are a little bit of caveats before we carry on with the rest and get into some of the conditions. But I think with connective tissue disorders, we do, as musculoskeletal therapists, we need to not forget that these exist. They are reasonably uncommon comparative to some of the other diseases. So if we take Sjogren's syndrome, for example, then that affects about 0.5% of the population. Comparative to rheumatoid arthritis, affects 1 to 1.2% of the population. So about twice as prevalent. But if you lump the connective tissue disorders all together, so the three we're talking about today, so Sjogren's syndrome, lupus, systemic lupus erythematosus, and undifferentiated connective tissue disorder or disease, then that probably makes them about equal with rheumatoid arthritis. So you aren't going to come across them. Now, the real issue for us as musculoskeletal therapists, and I think this is why people do forget that they exist or don't know a lot about them, is they very commonly have predominantly non-musculoskeletal symptoms. So again, if we go back to something like rheumatoid arthritis, the main complaint would be heat, redness, swelling, pain of joints, and that quite commonly would end up in a physiotherapy clinic or a musculoskeletal clinic. But these connective tissue disorders, they're predominantly non-musculoskeletal. So for example, when we talk about systemic lupus erythematosus, really we're looking at things like rashes, kidney problems, clotting disorders, hair loss, depression, fatigue, those kinds of symptoms, which aren't necessarily directly musculoskeletal, but they do have some musculoskeletal manifestations. So the real challenge is that these patients might present in a musculoskeletal clinic with what could be considered relatively mild musculoskeletal symptoms, but when you combine all of their other multi-systemic effects together, then what you see is this connective tissue disorder. So sometimes we have to be the ones that are going to glue those things together. They do come with significant investigation challenges as well. So it isn't easy to, you can't just do an X-ray and see what the problem is, or an MRI. Even in something like rheumatoid arthritis, at least with ultrasound, diagnostic ultrasound, you've got a real good hope of seeing that inflammatory synovitis, whereas we just don't have that in these connective tissue disorders. And even the bloods are not that accurate either, especially when you're not used to interpreting them. And really, we need rheumatologists to deal with that for us. So combining these things together, these are really challenging. The delayed diagnosis in lupus is approximately 16 years. So patients have symptoms for approximately 16 years before they're diagnosed. And that's obviously very problematic that they're waiting that long, because what we do know about inflammatory disorders is the longer you wait to have them diagnosed, the less likely the medications are going to be effective. So that delayed diagnosis is really problematic. So we do need to recognize them. And hopefully, as we go through here, I'll be able to give you a bit more of specifics on how you might go about doing that. And there will be some questions, I think, in this which you probably aren't asking as standard, and you may wish to ask a select number of patients. And again, hopefully I'll be able to give you a way of narrowing down some of those patients. So you don't need to necessarily ask every patient the questions, but so narrow down which ones you might want to do that for. So a real challenging area, especially for us as musculoskeletal therapists, I must admit, I still find very difficult. You've asked me what are all the symptoms of a potential kidney disorder, and you're going to find me using some sort of resource to try and get the answer with any great detail. Not my giant area of expertise, I must admit, some of the especially visceral issues, but certainly something we need to start being aware of. So I want to talk about systemic lupus erythematosus, and I've front-ended this one. This is the one that's going to come up first, because I think it's probably the most likely the one that's going to come into a musculoskeletal clinic. It's probably the most likely to cause the musculoskeletal symptoms, so joint pains, maybe arthritic even symptoms. And it's difficult to know how prevalent it is. As we mentioned, patients waiting 16 years for diagnosis. So here we've at least 0.1% in the UK. So certainly not completely, super rare. 1 in 1,000 people with SLE. And it's it's likely to be higher than that as people wait for their diagnosis, or they misdiagnosed as other things, especially things like fibromyalgia, persistent pain syndromes, or chronic fatigue, or something similar. We've got very high female to male predominance, so 10 females going to be diagnosed for every 1 male that's diagnosed. And we've got a peak onset between the ages of 15 and 44. So it is a younger diagnosis. And if we think about this, again, 16 years delayed diagnosis, then on average, then it's likely that these patients are going to come in sort of in their mid-20s, mid-30s by the time they're getting to us. But we need to be vigilant in those younger patients. And if you are seeing a pediatric cohort as well, then the age 15 obviously slips into that. So really quite young when these patients start with their symptoms. Many will report it beginning with the onset of menstruation or something similar as they begin to develop through puberty. And then carrying on, it does onset a little bit later, but it is definitely a younger onset with SLE. One thing to note is African-American females have about twice the likelihood of being diagnosed as a Caucasian female. So if you think about an African-American female population, you're looking about 20 diagnoses to every 1 male diagnosis. So much, much more common in African-American females, and that really does go across the board in our connective tissue disorders. So on what I've done on this slide, these are the main symptoms associated with systemic lupus erythematosus, or SLE. These aren't listed in order of prevalence. What I've done is I've listed these more in the likelihood of us seeing patients in our musculoskeletal clinics. So at the top here, we've got arthralgia, myalgia, and arthritis. So the most likely thing that patients are going to come into our musculoskeletal clinic with is sort of general joint aching or general muscle aching. So they might describe widespread pain. They might describe pain that's worse with activity or exercise. They very regularly are misdiagnosed as things like, as we mentioned, fibromyalgia, hypermobility syndromes, those kinds of issues. They sometimes will present with a specific arthritis, and that tends to mimic a rheumatoid arthritic pattern. So it's tending to affect the smaller joints of the hands and feet. You do see some redness, heat, swelling, and it's not massively uncommon for patients to be referred into rheumatology with a possible rheumatoid arthritis when actually they have SLE. One key aspect we're really looking for is quite severe fatigue. Almost all SLE patients will report fatigue. So that doesn't really distinguish it from something like fibromyalgia, which is unfortunate. But if a patient doesn't report fatigue, then they're fairly unlikely to have SLE. The rashes are characteristic, and this is where the erythematosus component comes in. And as the picture shows here, what you get is a butterfly rash across the bridge of the nose and the cheeks. And these are really quite common in SLE, if not sort of constant, really. But what these tend to be is they tend to be reactive to sunlight, and they do tend to go up and down, but commonly, as I mentioned, across the bridge of the nose and into the cheeks. This is much more difficult in the African American cohort. It doesn't show up so easily, and we don't tend to have medical pictures. I couldn't find one, for example, of what that looks like on non-Caucasian skin, so that's a real challenge. But quite commonly what happens is that the females that are attending with this think that they're getting sunburn, so it's reactive to sunlight, so they go out in the sunshine, obviously, and then they get this redness, this rash come up across the face, and they think they've burnt easily, or they do burn easily. So that's something to make sure that we're asking our patients, and they may well have photos on their smartphones these days of that kind of rash. Miscarriages is a question that we do need to be asking these patients as well, and that is characteristic of something called antiphospholipid syndrome, which is related to miscarriages and blood clotting. So what happens is these patients with SLE, it's also affecting their ability to clot the blood, and then that causes the miscarriages. So in these patients with widespread pain and fatigue and myalgia and things, or arthritis, I do ask them about whether they've had any previous miscarriages. A single one, I usually will not put any weight into that. But if they've had multiple miscarriages, then that would go into my clinical reasoning process as well. And then finally, hair loss is quite common. So they will report sort of hair falling out in chunks when they're washing it, those kinds of things. So what we're really looking for is these other systemic effects. It is a connective tissue disorder, so a lot of patients will end up in places like nephrology with kidney issues, some with liver problems as well. So it might well be that actually they are under the care of other departments. What my experience is those patients who start with the other other organs being affected first before musculoskeletal issues, is that those are much more significant and they get managed, and they tend to be diagnosed with SLE before the musculoskeletal symptoms start. Patients who start with musculoskeletal symptoms tend to then develop these organ issues later. So if you've got a patient who maybe they've been diagnosed with fibromyalgia or something similar, and then they develop issues with their kidneys, then that can be quite a big marker to think, okay, maybe actually this is something else that's causing it. Or let's say they are diagnosed with fibromyalgia and then they go on to have 2 miscarriages or something like that, then you would really start to think about what's causing those symptoms. The other one that can happen with SLE is neurological issues. But again, these tend to be the predominant symptom, and they tend to end up in neurology. I haven't seen any patients in my past clinics who have the musculoskeletal symptoms and then generate the neurological symptoms. It tends to be that the neurological ones are the predominant ones. They end up under neurology, and then they may develop musculoskeletal symptoms after. So it's not necessarily something that you need to necessarily be looking out for. So the medication management of SLE is a little bit varied, but also not that targeted. So in other rheumatology diseases, we have really quite specific medications that target pathways to try and interrupt the inflammatory process. In SLE, we really don't have that. So mild lupus, you're looking at a mixture of non-steroidal anti-inflammatories and hydroxychloroquine. Moderate lupus methotrexate can be used, and that's likely to be used if they have any peripheral arthritis. Azathioprine is a similar sort of drug to methotrexate, and quite commonly resorting to prednisolone. And then in severe lupus, you end up with prednisolone and maybe some biologics if, again, they've got something specific to target, like peripheral arthritis. So we need to be mindful of this. These pretty much all come with issues that might affect later down the line. So non-steroidals have an effect on the gastrointestinal system and also the cardiovascular system. Hydroxychloroquine can affect patients' eyesight. Methotrexate can affect patients' livers, and prednisolone is going to cause, if that's used long term, is going to cause low bone density, and that's going to be a big problem as well. So if we're seeing patients in our musculoskeletal clinics with SLE, we need to be considerate of those, especially if they're taking the prednisolone, and what we're going to do, what can we do about the low bone density, and keep an eye out for those kinds of effects. But really, I wanted to use this slide to demonstrate how sort of the lack of targeting we have for this kind of condition, which is why we really need to try and pick it up as early as possible to make sure that we're not delaying that diagnosis if we can. So I want to move on to Sjogrens syndrome. This one's a little bit easier than SLE to pick up. It has some, the symptoms are a little bit, or the non-musculoskeletal symptoms, I should say, are a little bit more specific and easier to pick up with questioning. So this is a little bit more common than lupus, and this is about 0.6% in the United Kingdom, again with that African-American female predominance as well. We're about 9-to-1 female to male diagnoses here, and these are older patients than the SLE patients. So our peak onset is age 50 to 60 this time. So commonly what we'll get is really similar musculoskeletal symptoms to the SLE patients, but they're obviously, these are a little bit older. So this time we're probably looking at people with maybe diagnosed with osteoarthritis or whatever else they might get diagnosed with elsewhere. Really, again, we're going to get the arthralgia, the myalgia, so this really sort of generalized pain with significant fatigue. But what we're really looking for in these patients is these excretionary issues. So what happens in Sjogren's syndrome is the inflammatory effects start to cause dysfunction in excretionary glands. So most commonly is dry eyes. And these usually manifest themselves alongside the musculoskeletal symptoms. So dry eyes, so commonly the patients are using sort of fake tears, a dry mouth. They will obviously drink a lot of water, and this is sort of a constant dry eyes and constant dry mouth. It's not necessarily caused by something. And the other one to keep an eye out for is vaginal dryness, although that tends to be a little bit less common as at the onset. That tends to come on a little bit further down the disease course. So what you'll get is dry eyes and dry mouth, and then they will develop vaginal dryness a little bit later. So anybody working in women's health, you might see that as the presenting complaint, and then you map that onto arthralgia, myalgia, fatigue, dry eyes and dry mouth, and that's where you might have to work backwards a little bit comparative to those of us in musculoskeletal practice who are concentrating on the musculoskeletal symptoms and then adding on these other non-musculoskeletal symptoms. So again, with these patients, you're a bit less likely to see the specific arthritis. So you do just get this sort of general aching, but we have the specifics of the dry eyes, dry mouth. So I ask patients, do they have dry eyes? Do they use replacement tears? Quite commonly, you don't need to necessarily ask them about dry mouth because they can't go 2 sentences without drinking their water. Then obviously vaginal dryness is something that you need to broach a little bit carefully. The Sjogren's syndrome pharmacology is very similar to SLE. It's pretty much the same. In fact, when you look at the medications, you can obviously use artificial tears to help with the dry eyes, and there are saliva sprays available as well. And then topical estrogen and vaginal lubricants can be really quite effective to manage the vaginal dryness. So all in all, the Sjogren's syndrome a little bit easier. And you don't need to necessarily worry about it if they don't have those excretionary symptoms. So that brings us on to undifferentiated connective tissue disorders. So this makes up about 50% of all of the connective tissue disorder cases. And these are the ones that are most likely to attend our clinics. And the definition of an undifferentiated connective tissue disorder is that basically they have symptoms of a connective tissue disorder, but they don't have enough of the specifics to fit a sort of diagnostic criteria. So, for example, a patient might attend with generalized muscle aching and some dry eyes. You go on to do a blood test and it shows an elevated ANA, but they don't have enough particularly to diagnose them with something like systemic lupus erythematosus, or they don't have enough in to meet the diagnostic criteria for Sjogren's syndrome. So these are the real challenge, and I think this is what lends itself to that 16-year delayed diagnosis in lupus. So at some point, what they're likely to have is this start of symptoms which are not particularly specific, and then they go around healthcare, they try and find some help with that, and then eventually maybe more symptoms present themselves, or the current presenting symptoms deteriorate, and then they meet a diagnostic criteria and they end up being referred on for management. So you can see how that might extend out the periods of time. But this is where we're sort of landing at. These patients sit in the middle of our onset. So we saw SLE onsetting quite young, 15 to about 40, and then the Sjogren's syndrome onsetting a little bit older, 50 to 60, and these patients are onsetting around 32 to 44. So if they don't develop SLE early on in their teens or early 20s, then it waits a little bit, and then they'd start to develop this undifferentiated connective tissue disorder a little bit later. Of note, This is the opposite in our predominance. So about 72% of these patients are Caucasian. So if we think about what that means for our African American females, is when they develop a connective tissue disorder, it's usually clearer than it is in the Caucasian population. So if you think about something like Sjogrens Syndrome, for example, what will happen in a African American patient, a female patient who develops Sjogren's syndrome, is she would get joint aching, muscle aching, dry eyes, dry mouth, probably vaginal dryness. Whereas a Caucasian female is going to develop some muscle aching and maybe dry eyes. And then those symptoms are going to deteriorate slowly over time, maybe incur some mouth oral dryness, and then maybe incur some vaginal dryness later. So you get this sort of slower onset with the Caucasian females. So they're difficult. They're a bit more difficult to pick up, and this is where we need to keep our differential diagnosis ticking over time, and we need to make sure we're not ruling out. We're just considering whether connective tissue disorders are going to be the issue. So as I mentioned, they have these symptoms of a connective tissue disorder, and a lot of fibromyalgia patients, chronic fatigue syndrome patients, are going to, I should add in long COVID now, I suppose, as well. All of those patients are going to have symptoms similar to this. So this is widespread sort of low-grade pain. And by low-grade pain, I mean not really active arthritic pain. So they're going to have this widespread pain with fatigue. Then maybe they are going to have a rash across the face. Maybe they're going to have dry eyes, dry mouth. Maybe they've got other organ involvement. Maybe they've got some hair loss. But they're not really fitting a specific criteria. So really you're taking maybe one or two or three of the symptoms and not multiple of them to give you a real easy point towards what's causing the symptoms. They don't fit any of these specific criteria. So, like you said, you might have the rash plus the dry eyes. You might have myalgia plus fatigue. So they're not really fitting any specific criteria, but we need to keep vigilant for those. Very often they've got this milder disease, and by milder we're meaning they might have multiple symptoms, but each individual symptom is sort of lower grade, and so they sort of trickle along, not really improving. I've noticed in the chat someone's mentioned something about menopause type symptoms, which is obviously similar, with the sort of widespread pain, fatigue, those kinds of symptoms, even the vaginal dryness. And so what you're seeing is what can quite often be put down to something else, but actually what they've got is this undifferentiated connective tissue disorder. Now, the question really becomes is, how many of these people do we investigate, refer to rheumatology, all those kinds of things? And that's a really difficult question to answer. And I don't have any specific answers to that, other than you need to be comfortable with the person in front of you and what your differential diagnosis is. I usually move towards those sort of specific things we can push towards an actual connective tissue disorder, like the butterfly rash, for example, or you can get tests for dry eyes. There's called a Schirmer's dry eye test, where you put a piece of paper in the eyelid. Sounds horrible, and it depending on if they have, I think if it's less than 5 millimeters in a few minutes of liquid, then they've got sort of pathologically dry eyes. So those kinds of things, we've got this real specific marker of a connective tissue disorder, then I would be looking at further investigations. So and it makes sense, so that what I've sort of just described, that these patients have this milder disease, because what we're essentially doing is waiting, for want of a better phrase, we're waiting for these extra symptoms or these deteriorated symptoms to show themselves. And you can sort of see, you can add a silly example, really. It's someone with fibromyalgia, widespread pain and fatigue, and they come back to clinic 3 or 4 sessions later, and suddenly they've got this butterfly rash. And you go, oh, it's lupus, systemic lupus erythematosus. And you think, oh, okay, well, that's a bit more obvious now. But before, they looked pretty much exactly like this persistent pain patient. So a person with persistent pain. So it is really difficult, and we're often waiting for that thing to show itself. Again, pharmacology is similar to SLE. So you're going to be, in the mild situations, you're going to be using NSAIDs and maybe hydroxychloroquine. Then later it's pretty much steroids. And again, if we think about the age and the demographic of these patients, so they're going to be sort of middle-ish age females, then they're already going to be at risk of this bone loss. So what can we do to try and help us as well? So blood testing has got some use, and really this is where I slightly differ on my advice on other rheumatology conditions. The other conditions, rheumatoid arthritis, ankylosing spondylitis, so on and so forth, is really, I advise against investigations as much as possible. Go off clinical symptoms, and we refer into rheumatology off the back of that, and we do investigations based on what's needed for the pathway, essentially, unless it's your job to do the investigations. Now, in connective tissue disorders, I would advise that we do some testing, but we've got to be careful with how we interpret these. So ANA is a really useful blood test, and the downside of ANA is it's quite commonly positive in the general populations. Maybe 20-25% are positive for an ANA, but what we're really looking for is this high, it's called high titer of ANA, so 1 to 320 plus, and commonly 640 or even higher than that is common in lupus. So we want at least 1 and 320, and 95% of your lupus patients will be positive, that highly positive for ANA. So really you can use that as a ruling out tool. So if you've got patients with fibromyalgia or whatever other persistent conditions we've talked, or either menopause, etc., and you do an ANA test and it's below 1 in 320, then so 1 in 160 or below, then it's almost certainly not lupus, and you can move on. Sjogrens Syndrome, they have a reason, it's not quite as high as lupus, but they do have positivity in ANA as well, using the same titer. But we can also look for other auto antibodies, sort of called anti-Rho antibodies and anti-LAR antibodies. And if these are positive, then we could look for a rheumatology review there as well. So what you're doing is you're taking these patients with this generalized muscle aching, joint aching, plus fatigue. Maybe they've got these other systemic issues as well. Then you map on the blood testing, and if that's significantly positive, then we might say, okay, let's send these patients to rheumatology for further investigations. Unfortunately, I don't think we're going to get enough off just the clinical symptoms to be able to. We'd be sending 1 million patients to rheumatology every week if we do that, as we've already mentioned it. The overlap with other conditions is so high, so I want to map on those and make sure that we're referring the correct patients. In the undifferentiated cohort, then you might see one of these positive blood results. There are others implicated as well, but they're not usually done in primary care. But you might see that. So it doesn't help you that much unless you see a strongly positive ANA. Then that might help you as well. But what I'd be really looking for is just noting down that the patient maybe has an undifferentiated connective tissue disorder, but it likely is something else or whatever it is. And I would be, those are the kinds of patients I'd be having clinical conversations with. Other other professionals or the GP or a rheumatologist or something. Is this worth referring into rheumatology, do you think, for further investigations? Or should we manage this for a while and see what happens? And if they're not reacting like you would expect someone to react, then maybe that's your time to think, okay, we'll go on to investigate this further. Unfortunately, there's very little role for imaging in the connective tissue disorders. You're not really going to see very much. The only difference to that really is if you've got red hot and swollen peripheral joints, and then using ultrasound to have a look and see whether there's active synovitis is a really good idea. That's really something that can be that could be quite useful. The difficulty then, of course, is you're not really going to be able to differentiate that easily from something like rheumatoid arthritis. But then, if you're referring into rheumatology, then you've got a good outcome. So I just want to finish with another couple of little bits. I've not really included it in here because it's not really a musculoskeletal symptom, but something else that we can look for is Raynaud's disease as well. That is very commonly present in our connective tissue disorders. The problem is, obviously, it's very common in people who don't have connective tissue disorders. So it's just something else to add in as a possibility. You're going to see a lot of patients, especially with lupus and Sjogrens syndrome, with Raynaud's, but then you see a lot of the normal population with Raynaud's as well. So it doesn't really give you lots of information, but it can be something else that's associated. And really, hopefully, that's given you a good overview on what to look out for in these patients, mostly with generalized muscle aching, generalized joint aching, those kinds of issues. So as I've mentioned, I have made a book. This is available printed if you're in Europe. It's available as an ebook if you're outside of Europe, and really it gives you a bit of a description of each issue. With top three we've talked about there: the systemic, the SLE, Sjogrens Syndrome, and undifferentiated connective tissue disorder. It also then goes into systemic sclerosis, polymyositis, and dermatomyositis, and it also has some clinical scenarios in there. So hopefully that will be really useful to check out as well. So I do want to go on and do some questions with you guys. So hopefully you've filled up the Q&A tab. I noticed in the general chat, Michelle's written, is there usually a family history of connective tissue disorders or other rheumatology conditions? And really, it's not that specific. They often will have a history of inflammatory issues, but you can't really be that much more specific. And unfortunately, a lot of people do have a history of a family history of inflammatory conditions, because when you add them all together, they become a little bit more common. So, if the patient is attending possibly with symptoms suggestive of lupus, and their mum or their aunt or sister has lupus, then I would be pricking my ears up at that. But they, it's not that specific. Unfortunately, there's a lot of these patients don't have any family history either. Great. So we've got a few questions in here that we'll get through as many as we can over the next sort of 15 minutes or so. So Sam's the one with the top one. Oh, it's moved. Sam said, can you get a mixed picture of SLE and Sjogren's? So yes, you can. Two sort of ways you could get that would be the undifferentiated connective tissue disorder, where as I mentioned, you could have someone with the butterfly rash and dry eyes, for example, but maybe they don't have positive blood results, significantly positive blood results. And of course, what we're doing is, as I popped into the sort of complexity slide right at the beginning, medicine makes these distinctions, these diagnostic criteria, which really help with research and management, those kind of things, if you bunch the patients together. But really, these patients are all individuals, and they have this varying sort of disease presentation. And so if you sort of think of connective tissue disorders as an umbrella term, and then underneath you've got these different diagnoses, so you've got SLE and you've got Sjogren's and you've got systemic sclerosis and myositis, then all you're doing is they've all got a connective tissue disorder. It's just some of them have more like these types of symptoms, some have more like these types. So you will get this sort of blending picture as well. And that sort of leads me into James Holland's question. He said, have you ever seen a patient diagnosed with lupus without the classical butterfly rash? And the answer is yes, definitely, for sort of the same reasons. So you can get lupus nephritis, which is sort of the predominantly kidneys affected, or neurological lupus. And so they may not be systemic lupus erythematosus because they're not presenting with the rash. So it might be that you have a slightly different, so you've got connective tissue disorders, then you've got lupus over on one side, and then that's split into different types of lupus as well. So you're getting into more complexity, and not all of the patients have the butterfly rash, even with what is classically SLE. And as I mentioned, if you've got an African American patient, then you might not be able to see the rash. So it's part of the diagnostic picture, or the suspicious picture. It wouldn't be, if they don't have the rash, I wouldn't be ruling it out, let's say. Sam's asked, do they all present with all of the above symptoms together, or can it progressively present with these symptoms over the years? So that sort of speaks to our undifferentiated disorders, to connective tissue diseases to start with. So what you're getting is you're getting some of the symptoms starting, and then you're likely building others on top. So if you think about a patient who has, again, like arthralgia and very dry eyes, then probably what would have happened a number of years ago is someone would have managed the dry eyes, and then they might have gone somewhere to try and manage their joint pains or their arthralgia. Then you add in sort of ANA testing or some of the newer autoantibodies, and they have one of those positive, and then you get this connective tissue disorder. Undifferentiated connective tissue disorder, because you've got one blood test and you've got symptoms suggestive of connective tissue disorder, but they're not fitting those diagnostic criteria. So it becomes all this blurred mix. And then what happens is later, as the disease course progresses and they get more symptoms because they're not being managed sufficiently, then they fit a clinical criteria and they become systemic lupus erythematosus or whatever. What's happening these days is that you get diagnosed with an undifferentiated connective tissue disorder, treat them with hydroxychloroquine or something, and then that suppresses the inflammatory system, and they never go on to develop the more symptoms. So they get left with this undifferentiated connective tissue disorder, and they never develop on. Okay, apologies if I missed a couple of questions here, because it does shift around as you vote them up and down. Ori, apologies if I'm mispronouncing your name. Ori has said, does the diagnosis depend on antigens, or might you have a clinically seronegative diagnosis? No, it doesn't entirely depend on the antigens. Yes, you can have a seronegative diagnosis. They are less common, as we mentioned, in sort of SLE, with the 95% having a high ANA. So 1 in 20 patients will have a negative ANA and still have SLE. What I would say with those patients is when they are diagnosed, they have quite clear symptoms. So they've definitely got a butterfly rash, maybe another organ involvement, arthralgia, myalgia, fatigue. It's quite obvious. The most likely seronegative ones are the undifferentiated connective tissue disorder ones, who, as we mentioned, they don't then fit the clinical the clinical criteria, the diagnostic criteria. So it's it's sort of a decision that's made by the rheumatologist on all of the available information. Laura's asked, is there a hereditary element to Sjogren's and SLE? There definitely is, but it's not as obvious. There's a lot of genes that are involved, and it's a bit more complex than something like ankylosing spondylitis with the HLA-B27 positivity. So it's a bit more difficult. James has said, do you know whether bloods for ANA and anti-Ro/LAR are expensive to do? The ANA is very cheap. The others, I don't know, is the honest answer. Our local lab have stopped primary care clinicians referring HLA-B27 due to the diagnostic. Yeah, HLA-B27 is a funny one. The ANA is definitely cheap, and ANA is probably overdone in primary care, if I'm honest. It's difficult when they're stopping them doing them, because there's another question I've noticed here is Sam's written, will rheumatology accept if ANA is negative? Well, if you can't get it, then you don't know if it's negative or positive, so you're going to butt up against it. You should be able to get ANA for sure in primary care. The anti-Ro and anti-LAR ones, you're less likely to need, if I'm honest, because what you're going to see is those Sjogrens Syndrome patients coming in with the dry eyes, the dry mouth, the vaginal dryness. So you're already going to be quite suspicious because of those symptoms. The lupus is a bit more of the challenge because the other organ involvement is a bit more difficult. So I don't know about the expense. To go to Sam's question about will rheumatology accept if ANA is negative, I would suspect they won't unless you've got very strong clinical suspicion that the patient has the connective tissue disorder. Unfortunately, like as I mentioned, what you see if you work in rheumatology is what you see is from primary care is a lot of referrals for patients with widespread pain and an ANA of 1 in 80 or 1 in 160, and what I would say is that's not significant enough. It needs to be up around 1 in, as we mentioned, 320 or higher, and that's what rheumatology are really looking for. So if you've not got a really high suspicion, then they're probably going to bounce that. So as Sam's gone on to say, the patients circle around with diagnosis of fibromyalgia or ME or something similar. And that is really difficult because of this sort of low ANA. But if you've got that really strong clinical suspicion, then that can help you. I think where am I getting to here? Answered that one. We've got a question. If a patient has hypermobility syndrome with a face rash, can this be an SLE picture? Question's gone. Where's it gone? GP has seen face rash and said it's rosacea. So hypermobility isn't a symptom of these connective tissue diseases that we've talked about. So it's not related to SLE, Sjogren's, or the undifferentiated connective tissue disorder. Now, what we need to appreciate about hypermobility syndromes is somewhere up around 20% of the population are going to have a hypermobility syndrome, potentially. So there's going to be an overlap. There's going to be a big overlap. So what are the symptoms of hypermobility? You get widespread pain and those kind of things. So potentially fatigue as well. So what if you've got the face rash, then that's what you're going to then sort of need to be concentrating on with regards to the connective tissue disease. And then can you differentiate out what is pain caused by hypermobile joints or and their related injuries, or is it unrelated to that in some slightly different way? And that's really difficult without a sort of without a patient in front of us. If the GP is happy that it's not a butterfly rash, and like I said, the butterfly rash is quite specific, then you're less likely. But then you're going to, I think, in that sort of situation, you can go to the bloods, and if you've got a high ANA, so over 1 in 320, then or higher, then you can be more confident that it might be SLE. If it's low, then you're much more likely to think, okay, it's probably a hypermobile syndrome. Lucy has asked, can ANA vary over time, and does this relate to disease activity? So it can do, and yes, it can relate to disease activity. It tends to once it is positive, it remains positive, but that titer can go up and down. But it's not rapidly changing. So it's not like on Monday you've got a 1 in 80 ANA, and then on Tuesday you've got a 1 in 600 something. It's more likely to be high for a significant period of time, then lower over time, and then raise. So you wouldn't be saying, I'll wait until your symptoms are bad and then get an ANA test, because it's going to stay up much longer than that. Fiona's asked, what advice can we offer these patients with probable symptoms when they are waiting 12 months to see rheumatology? Yeah, it's problematic, isn't it? So the general advice for these patients from our point of view is we want to maximize their general health. So we're looking at general activity levels, exercise as possible, a healthy diet, no smoking, minimal alcohol intake, sleep as best as possible, reduce stress as much as possible. However we want to go around all of those things. There is a little bit of evidence regarding protein intake and that being helpful. So looking at getting people to take higher levels of protein can be beneficial. The fatigue management can be done with things like pacing or activity management, that kind of thing. It's really important that these patients stay in work. All of the rheumatology disorders have a really negative outcome if patients stop working. So even if it's modified duties or reduced hours, it's really important to keep in work as best as possible. So that's kind of general advice. The activity can be difficult when patients are very fatigued or they've got pain. So it's about what activity can they do? Can you gradedly increase that? And all those kinds of questions. Sarah's asked, is it common for patients with Sjogren's syndrome and Raynaud's syndrome to get foot ulcers, or could that be more vascular related? So Raynaud's is a vascular issue. So if they've got Raynaud's and ulcers, then those things are likely related. Hannah's asked, is there a general set of bloods you would recommend to request in primary care if you're suspecting a patient may have a rheumatology problem? No, I would be requesting specific bloods depending on what you think the rheumatology problem is. So in our case that we're talking about now, if you're thinking it's systemic lupus erythematosus, then what we want is probably get inflammatory markers, so ESR, CRP. We definitely want that ANA. If they've got any redness, heat, swelling of their joints, you might go on and get a rheumatoid factor and an anti-CCP. But if they don't have red hot swollen joints, you wouldn't go getting that, and that would be trying to differentiate between rheumatoid arthritis. I would get some general bloods, things like liver function, kidneys, maybe a bone profile as well. Vitamin D is usually quite a common one. Most of the rheumatology disorders, patients have a low vitamin D. It's not diagnostic in any way, but it's definitely something useful to have. But really, there's in a number of primary care locations that I've aware of, they have a rheumatology screen that they tick as a blood testing. I don't like that at all. I'd much prefer a reasoning process goes into specifically wondering, what is the disease I think it is. These are the bloods that I need, because there is such a high positive and high negative, so high false positive and false negative rates with most of the tests. So that's problematic. So really want to be doing it specifically depending on the disease process. Right, I think we're getting, apologies if I missed any questions, I think we're getting towards the end here. G-News asked, is discoid lupus milder than SLE? Can patients with discoid lupus get SLE as well? So you get some patients with SLE, which is mild in inverted commas, and some with discoid lupus, which is more severe. So I wouldn't say it's necessarily milder. It depends on the individual. And you can get multiple, as we talked about, with this sort of overarching diagnoses. So you've got a connective tissue disorder, and then we're watching sort of the patient potentially get more symptoms if they're not managed appropriately. Not everyone will, but some will develop more as you start at the undifferentiated connective tissue disorder, and then you push onwards and you become SLE, and then maybe something else, and so on and so forth. So yes. Right, we've been going an hour, so let's do our last question from Haley. She's got a lady who fits SLE clinically, only ANA positive, but no ratio given. I've referred to rheum, but is it unusual to not get a ratio? That is unusual. I don't think I've seen that before reported, where it's positive but not given the titer. And like I say, I really want the titer, to be honest. So if they fit clinically, that's great. That makes life easier. If the ANA is positive, I'm pretty much ignoring it unless it's 1 in 320 or higher. And in your case, it sounds like because they're clinically fitting, then you don't necessarily need to hang too much weight on that ANA. But if they were less overtly obvious, and then you had a low titer, especially something like 1 in 80, then you really... If that ANA is positive, but it's 1 in 80, then that's when rheumatology are going to bounce that back at you, unfortunately. Okay, so thank you very much, everybody, for listening to me for the last hour or so. I hope you found that useful on the old connective tissue disorders as an overview, and starting to understand some of how those conditions might present. Please do consider having a look at my website and the shop. Of course, if you do want anything from the shop, I would obviously advocate all of the things on there are great because, I wrote them. But if you use the discount code Connective, then you'll get 20% off everything. I think that will last. That discount will last for the next day or so, it'll probably run out on Thursday night or Friday morning, so do check that out. I've got courses on there, and also my recorded course, which is being upgraded at the moment, which gives you as much information as I possibly know all about rheumatology. But finally, thank you once again for spending this time with me. You will receive an email first thing tomorrow morning. It'll have the slide deck attached, so you can keep that for your reference. Hopefully found that useful, and speak to you on social media or other stuff. Might do some more webinars because this one's gone pretty well. Seeing some names that I recognize. Tom Borges is there. Nice to speak to you, and have a good rest of your evening, everybody.